Hey everyone, welcome to today's Provide First Aid course. My name is Abby and I'm going to take you through everything we need to today. So a little bit about myself is prior to working for Rural Response, I was an army medic. I was posted to Darwin and Brisbane in that period. Whilst I was in Brisbane, I was fortunate enough to spend a lot of time on road with the paramedics, including their critical care paramedics. I've also worked in a variety of hospitals around Australia. Most of them were in Brisbane, in the emergency departments, operating theatres, and even their burns ward. I discharged from full-time Army. I'm currently in the Army Reserve, still here in Adelaide as a medic, instructing majority of my time for Rural Response. I teach their CPR, first aid, dynamic environment courses, and also remote courses. So something that I'm very passionate about, and so is Rural Response, and obviously something I'm really fortunate enough to work for a company that think the way I do, and what we strive to give you is just that empowerment to provide vital skills during critical situations. So with that, critical situations can be any time. You could be at work, you could be driving home from the shops, at sports on the weekend with your kids, or at home. It doesn't matter. You can use these skills anytime. So I'm just going to quickly play this safety brief video, and then we'll get on to what we need to.
Our training methodology utilises realistic simulations to create a training environment that is as realistic as possible. This involves the creation of staged medical emergencies for our students to train in. If there are any participants who feel that they may be adversely affected, either physically or psychologically, please let us know. To ensure safety, you must notify everyone immediately if you feel, expect, or see any actions that are possibly unsafe or have the potential to cause harm. You, as well as us, are responsible for maintaining a safe environment. At any point, anyone may stop a simulation by loudly saying, "Stop, stop, stop." When you hear this, everyone must stop what they are doing or saying and wait for further instructions from the trainer. As this is a Zoom course, please be mindful of the individual hazards within your environment. For example, water near electrical equipment, trip hazards, tables. Some of our educational content, images and videos may not be appropriate for younger age groups, and therefore viewer discretion is advised. The simulations are conducted in what we refer to as a safe container. This is a confidential space where you will be challenged and mistakes are okay to be made. If at any stage as part of the simulation you feel you need to call an ambulance, please call the Real Response Simulated Response Line on 0386581571. This number will also be placed into the chat function of Zoom. If someone is injured outside our scenario, you must call 000. After the course, if any student needs to further discuss one of the scenarios, they may contact us via our 1300 number on our website.
Alrighty, so that might be relevant during today's training or maybe during the face-to-face component, okay? Just what we're going to cover today, for those that are just completing CPR, Perform CPR will be the first part that is going to be done, and then anyone here for the remaining sort of course, being that Provide First Aid, we're going to do another video that will cover that content. All right, but before we do, just one more video to pop up before we get into the training content for today.
Did you know that I am 27% less likely to receive CPR than a man? So is your mother, your wife, your sister, and maybe even you. Research has shown that this is largely because first responders feel uncomfortable administering CPR whilst exposing a female's chest. But you know what's more uncomfortable than being exposed in public? Being dead. Real Response has now made it possible for you to practice on both male and female mannequins in our first aid training sessions. Together, we can close this stigma-related gender gap and save more lives.
Alrighty, so pretty eye-opening type of video right there. We will have obviously female mannequins during our face-to-face CPR elements. All right. So now that we've done that sort of first bit that's required, we're gonna now go on to our legal and ethical side of first aid. So the first thing we're gonna cover off will be your duty of care. So do you think in your workplace you have a duty, like a legal duty of care to provide assistance to someone if they need it? And the answer is yes. All right. As part of your role as as a employee, you are required to make sure that environment is as safe as possible for anyone who steps foot on that sort of space. And if someone does injure themselves, you have that requirement to always assist where you can. However, that does change when you are not in your workplace and you are just in the community. So therefore, you do not have a legal duty of care. However, it then comes down to your moral and ethical type of responsibilities, and are you willing not to help someone if they need it? The little thing that comes with that, though, if you go over to someone and ask, hey, are you okay? You have now taken on that duty of care. So yes, just because you might not be in your workplace, because you've already taken that step to check if someone is okay, you now have taken on that duty of care, and you need to wait for further care to arrive. The Northern Territory have a rule in place that require that anyone, no matter what, provides assistance if someone needs help, if it's safe to do so. And as maritime law sort of permits, when you are out at sea, you are also legally obliged to help someone in an emergency also. So the Northern Territory and obviously out at sea have those rules that are a bit different to other state and territories. So with the duty of care, what protects you though? All right, because people might be fearful of getting in trouble for helping someone, whether they make a situation worse or maybe the unfortunate happens where that person does pass away. But the thing is, you will be protected. And no one has ever been successfully sued in Australia since the Good Samaritan Act was actually implemented. All right, that is your protection. And that comes under the Wrongs Act. All right. Really, really good at protecting those who choose to do a good thing and assist someone in need. Things to be mindful of though, and maybe something that they might look at is if you go outside of your scope of practice. All right, so everything we go through today and that you get assessed in, that is within your scope of practice. If you start watching Sandra Bullock movies and she sticks pens in people's throats to help them breathe, and maybe you cut someone's chest open and start doing surgery, that is not within your scope of practice. So you are not allowed to do that. And if you do, obviously that Good Samaritan Act will not protect you. So just do what you have been trained in doing. And just be very careful if you have something impairing your judgment. So alcohol or drugs, the general rule is if you would not legally drive a car, maybe it's best not to provide first aid, especially if you make a mistake. That Good Samaritan Act may not be protecting you. So that's your Good Samaritan Act, your protection. But things you need to also do when you want to help someone is always ask their consent. So consent is something that we always need to get from someone if possible. And we need to ask if they want our help, or maybe they're approaching us asking for our help. So that's what you do when someone is conscious. However, sometimes people might be unconscious or not responding to us. So what we do in that instant is we just assume or imply that they would give us consent, and we are going to help them anyway because they need it. However, things do impair people's judgment now. Drugs, alcohol, head injuries, diabetes, mental health, cognitive impairments like dementia, disabilities. There's a lot of things these days that do impact people's decision making. So, what are you going to do then if someone doesn't give you consent to help them, but you can see they need help because they've got a medical reason that they need help for? Well, you're going to call for help. All right. You can call someone who can help them. So, emergency services, paramedics, police, they have that protection that allow them to help someone if they need it. With that, maybe someone's conscious and they're got something impairing their decision making and they're yelling at you not to help them, and then they go, if I go unconscious, you're not going to help me. All right, I don't want you helping me. I'll sue you if you help me. And then they go unconscious. Now we're still going to help them, even though whilst they were conscious, they told us no, they don't want our help. We've respected that. All right. Medical trespassing, it's a form of assault. We're going to follow what they say whilst they're conscious. However, as soon as that person goes unconscious, even if they told us not to help them, we're now just going to assume or imply they are giving us that consent. All right. There's only those type of sort of areas. However, children are also regarded as having an impaired decision-making ability until the age of 18. However, most states now do permit younger people making their own decision as long as they fully understand what is involved. So talk to them, communicate, ask them questions, try and explain what you want to do to help them. If worst comes to worst, obviously you can call for help. That's there to help you and be a protection. You can help a child in an emergency, showing items to show them what you want to do to help them. There's other ways around that. All right, even trying to get in contact with the parent or guardian. But in an emergency, you can help a child. You might be thrown into an instance where maybe you're getting told not to help someone, maybe a bystander or a family member's they're telling you no. The thing is if that's a danger to yourself, you need to look after yourself first. But maybe ask them why. Maybe they'll be more comfortable if you instruct them on how to help the person. So just find sort of how you would do for that, and that might be something you might find if maybe English isn't someone's first language. There might just be that barrier. So even just showing items is a really useful tool. And lastly, the privacy and confidentiality that we need to respect for the person we're helping. We want to respect everyone, no matter who they are and their background. All medical history and information we are provided, we need to keep that confidential, and we only need to share that with the relevant authorities. All right, so the people who need to know that information, paramedics, police, maybe you've taken them to emergency department and you're telling the nurse or the doctor, okay, they're the only ones that are relevant with the person's care. What you don't do is start uploading it to social media, taking photos, sending it to colleagues, friends, and that gossiping type of sort of mentality. Be very careful when filling out casualty report forms and who that casualty report form's going to, especially if you're starting to give someone's private information like their past medical history, medications they take, because the workplace might not know that information. So just be very cautious with the information you provide, and also your surroundings. You might be in a very public setting. We don't want obviously to be asking questions that everyone else will be hearing. So trying to sort of have a awareness of your surroundings and remove them if possible, or try and move the crowd on. You can only do so much to move people along and stop them taking photos. So if any issues, just obviously contact the relevant authorities. So that is the legal and ethical side of first aid. If you have any questions throughout any of the training you're going to complete, maybe just write them down. And when you start to do that face-to-face element, that's when you can ask one of us instructors. So the next thing we're going to go over is just the chain of survival. All right. So the chain of survival has been sort of created in regards to a sudden cardiac arrest. And what a sudden cardiac arrest is suddenly outside of hospital with no pre sort of condition that you were expecting to put them into a cardiac arrest for. So the example I sort of use for this is like Shane Warne, all right, sudden cardiac arrest and that outcome from that. So what the chain of survival incorporates is early access, early CPR, early defibrillation, and also early advanced care, so paramedics coming to assist. But I like to start off this chain of survival and a link that's not even on the screen, and that's if you do nothing at all. So someone's in front of you, they've gone into a sudden cardiac arrest, and you just stand there and do nothing, and the chances of their survival is 0. They're not going to survive if you do nothing at all. So right now we're starting at anything on this screen is better than nothing. You're giving them a chance. The first thing we're going to do though, and the only thing we're going to do right now, is just call for help. And all calling for help or early access is going to give us is an up to 10% chance of survival. So we're getting there, but it's not the best. How long's a piece of string with how long it's going to take for assistance to come to us? All right. But if we incorporate calling for help and early CPR now, we're going to increase that number now to 32. So we've doubled that number from 10% to 32%, and we're giving them a better chance at surviving with starting CPR also. But we know defibrillators are everywhere now. I know here in Adelaide, banks, on the road, you've got shopping centres, supermarkets, gyms, aquatic centres. They're at the beach, they're on walking trails, they're just everywhere now. And probably in your location, you can think of where a few might be. So defibs, early access, early CPR, and now we've got a defibrillator early. We chuck it on. They're in a shockable rhythm. We shock them. We are potentially increasing their chances of survival up to 69%. All right, that's a big jump from just early access and CPR. So defibrillators are that tool we always want, and they should become sort of something we consider to have in our workplaces more often. And then paramedics arrive. So advanced care arrives to help us. This is the number that people think 90. I heard 100 yesterday from someone, but it only increases by 3%. That's because you, as first aiders, are the most important link in someone's chances of survival. You are the chain of survival for this. In movies, if you sort of remember what they do when someone's in a cardiac arrest, whether it's paramedics or nurses and doctors, they're still going to do CPR and defibrillation. And that's what you can do. All right. Paramedics can put cannulas in, they can give medications. One medication they do give in a cardiac arrest is adrenaline. You can give adrenaline for anaphylaxis via an EpiPen. You're not going to be trained at giving adrenaline or an EpiPen to someone who is in a cardiac arrest, okay? So that is not within your training. It's not going to be within your scope of practice as a first aider to give adrenaline in a cardiac arrest. All right, it is given for other things. You're just not trained in doing it, all right? So that is the chain of survival. Again, you are the most important link in the chain of survival, all right? You're going to be there first. And that moves us on to how do we know we have to do CPR on someone? Well, that comes down to our primary survey. And the primary survey is things we follow when we need to make sure we've checked everything properly. You can see there's probably an extra letter in there, maybe from last time you might have done a first aid course. It always happens, doesn't it? So we'll talk through each stage. So the first D, danger. We are the most important person. So us as the first aiders, we look after number one. We come first. Then it comes our bystanders, and last is then our patient, because last thing we want is our bystanders to go over to that patient, and now we've got more people we have to help. All right, so we want to make sure we have the least amount of people in that danger as possible. We always want to walk towards dangers though. because we get this tunnel vision when we start running, and what tunnel vision will do is make us miss things that might potentially be a danger. And unfortunately, has happened to people where when they've seen a car accident, they've got that tunnel vision to get there, and they don't actually check for any traffic as they hop out their car. And unfortunately, people have died from that. So we always want to look after ourselves and make sure that we get to the person safely, so that we can help them. And there's heaps of different dangers out there, all right? Traffic, fire, liquid spills, heavy objects, the weather, blood, animals, people. Okay, the list can go on. It's what you evaluate as that danger. All right, you may be able to fix the danger and remove the danger, but you may have to call someone to do that for you. Okay, so let's just weigh the option up. So that is our danger check. All right. And what comes after that is our response. And there's ways that we get someone's response, and you do it every day. All right. Talking to someone, seeing if they respond back to you verbally, or maybe they might show you by nodding, or maybe they hear you and they follow an instruction or open their eyes. So there's ways that people do show they're responsive. There's an acronym called CARES. Can you hear me? Open your eyes, what's your name, and squeeze my hand. All right. You're trying to get that verbal response. So if someone's like me right now sitting here, I am alert. All right. My eyes are open. I'm talking back. I am alert. Maybe you're approaching someone who's laying on the ground now, and you need to get their response verbally. So you're approached by the feet. You might give their foot a little tap to let them know you're there. And you ask them, hey, mate, can you hear me? Open your eyes. What's your name? And now you can get a bit closer and get them to squeeze your hands. If they don't respond to that verbal check, now we might have to inflict a little bit of pain. Your pain response is the last response to go. So to do that, we can pinch the trap or earlobes. They're two very simple, easy ways to do that. They might make a sound, they might flinch, or they might not do anything at all. All right. If they don't do anything at all, they are unresponsive. Your pain response is that last thing to go. So if they're not responding to that, they might have something blocking that response. After response, we need to send for help. There's two numbers we use here in Australia. They are 000 and 112. 112 is the international number for help. So in a lot of countries, what calling 112 will do is redirect you to their version of emergency services, okay? In Australia, just as great, we'll actually bypass your phone network if you don't have signal and use another network if there's signal from another phone provider. Most smartphones automatically do this. So when they say SOS only, probably using another phone's network. If it says no service at all, unfortunately, you need to find service to call for help. All right, the same as 112. But when you call for help, all right, there's one question that they always ask you that puts people under the most pressure, and it's called, and it's, where are you? All right. And when someone asks you where you are, you could know exactly where you are, and now you're suddenly forgotten. So there's a few ways we can find out where we are. We can look at street signs, but I don't know if anyone's tried to find a street sign in an emergency. They just disappear. You could ask someone, use your phone, landmarks. There's heaps of ways we can sort of do it whilst we're there. But there's also some useful apps. And I know everyone's probably thinking Google Maps, but there's one that incorporates that into it. And it's called the Emergency Plus app. This is free to download. And I tell everyone, if you want to get something out of today, download this app. All right. So you can see it's got different numbers, and it's got more with some drop down tools. It's got your location, so like Google Maps, your street address, your latitude and longitude. But I don't know if anyone has ever tried to tell someone on the phone with bad signal where you are via a latitude and longitude. Look how many numbers is there. So what someone's done, computer or auto-generated, they've divided the world into 3-meter grid squares, and they've gave each 3-meter grid square a unique combination of 3 words. So this is where that what 3 words down the bottom has come from. And maybe you open up your app and you're at this this stadium and you're on the side closest to us, and it's going to tell you your what 3 word for that 3-meter square you're currently standing in. So that will get help to you very, very accurately. Amazing app. All right. And this works in the water too. It works if you're camping, as long as you've obviously got the way that you can open this app and get that signal. So that is the Emergency Plus app. The next app I'm going to quickly go over is just the Good Sam Responder app. So this again is a free app to download, and the Good Sam Responder is a global smartphone app that alerts first responders to someone nearby in a cardiac arrest. So the Good Sam Responder is actually linked to 000, their communication center, and as soon as you call someone calls 000 and says someone's in a cardiac arrest, an ambulance will be dispatched. But what they will also do on this app is alert someone within about a 200-meter radius to let them know that someone's in a cardiac arrest and would they like to go there whilst emergency services are there on their way. What this is going to do is just bridge that gap for paramedics arriving and CPR defibrillation needing to be done. So using bystanders to get what we need done early. So that's just that app, and you get the option. You have to upload your certificate, and you have to say yes, you would go to that job. All right. So that's another app that you may consider downloading. So that is sending for help. One thing we can maybe consider is, do they need an ambulance? Maybe it's nothing serious. Maybe we could drive them to an alternative way, or go take them to emergency ourselves, or a GP. All right. So we have alternative ways to get help too. So sending for help doesn't always necessarily mean calling 000. So the C. All right, this is a new thing that might be new to you, and you're probably wondering, oh, the photo's changed now, and what is that? Well, that C stands for a catastrophic bleed, or I like to tell people, if you're going to struggle to remember, catastrophic is a controller bleed, a life-threatening bleed that will kill them if you don't. All right. Things to consider straight away is, what was the mechanism of injury? All right, what's caused them to be in this position? Was it a traumatic incident? Yes or no? A traumatic could be a stabbing or a shooting. They might have fallen off a roof. Maybe they were hit by a car or in a car accident, motorbike accident. All right, animal attacks. That's a traumatic sort of thing that could cause a catastrophic bleed, or machinery. What very unlikely will cause a catastrophic bleed right now would be maybe chest pain, asthma attacks, or anaphylactic reactions. So thinking about that mechanism of injury can give you a big suspicion whether or not they could have a catastrophic bleed or not. And it shouldn't take very long to check for a catastrophic bleed. We want to use our eyes, but we also want to feel and use our hands to have a look, because we always overestimate blood loss and we might not see it. Clothing might hide it. It might be wet. It might be dark. So the best thing is to also do a blood sweep. To do a blood sweep, you always start at the top of the limb and work your way down. And to do that, you're sort of just scrunching. And what you're hoping for, maybe they're wearing a leather jacket. And by scrunching at the top and working your way down, you might actually see blood coming out of the bottom of their sleeve. Or maybe you find blood on your hands. That's when you investigate. You have a look at what's going on. And if it is a catastrophic bleed, we need to fix it with either direct pressure or indirect pressure. So that is our catastrophic bleed check. After that, we're now going to move on to our airway. And our number one obstruction to our airway is our tongue. All right. So to clear the tongue off the back of the throat, we actually just lift our head back. Because if you put your chin to your chest and try and breathe, it's extremely difficult. If you look at the ceiling and try and breathe, it's a lot easier. So that will lift the tongue off the back of the throat. Then we use our pistol grip on our chin and we open up the mouth and we have a good look. All right, vomit, teeth, blood, food, anything can go in someone's mouth and we're going to look. If we find an obstruction, what we need to do is put them in the recovery position, make sure their mouth is open, and that we can use gravity to assist us. All right, I will never put my finger in someone's mouth. All right, I don't want them chomping down on my finger, and I don't want to put my fingers in to potentially make the obstruction worse. All right. So that is our airway check. After airway, we're going to then move on to breathing. All right. And how do we check someone's breathing? Well, we look, listen, and feel. But listening, putting our face next to someone else's face, especially if they're a stranger, we might not feel comfortable, especially with COVID. So the look and the feel are the two really, really important steps that we have to do. I put my hands sort of where the diaphragm is because it's a good safe area, and you probably will see more movement of your hand because most people actually have more movement from around their stomach. We hold that for 10 seconds, and 10 seconds will feel like forever. So please take your time. And what we want to see is we want to see 2 or more breaths in 10 seconds, because a normal respiratory rate for an adult is between 12 and 20 breaths in a minute. So 2 is that minimum number. What would we do though if someone's taking 2 or more breaths? Well, we'll put them in the recovery position now. But if we look, listen, feel for 10 seconds and they take 1 breath, or maybe they're not breathing at all, we classify that as now doing CPR. So what I'm going to do now, I'm going to go on to our next video, which will just demonstrate the DRSCAB up till the recovery position. All right.
I'm walking and assessing for dangers using sight, smell, and hearing. There doesn't appear to be any dangers present, so I'm going to check for a response. Hello, can you hear me? Open your eyes. What's your name? Squeeze my hands if you can hear me. There's no response to verbal cues, so I'll check for a painful response now. A tight squeeze on the traps will do this. There's no response, so I need to send for help. I'm going to ask someone to call an ambulance, and this would also be a good time to send for a defib. Next, I'm going to check for catastrophic bleeding. So I need to do a blood sweep of the whole body, checking both sides as you go. There doesn't appear to be any catastrophic bleeding, so I don't need to apply an improvised tourniquet. Next, I need to check his airway. So I need to tilt the head back, using a pistol grip of the hand, open the chin, and see if there's anything in the mouth. His airway is clear, so I don't need to roll him on his side to get anything out. Next is a breathing check. So I need to look and feel for 10 seconds. I should feel 3 to 4 breaths. He's breathing normally and unconscious, so that means I need to put him in the recovery position. First, I need to bend the arm over to the shoulder. Then I need to bend the same knee up. And I need to stretch the arm that I'm rolling to out straight. Then I need to push from the knee and the shoulder so he rolls onto his side. I need to unhook that bottom foot and drag the knee up so it acts as a brace, and do the same with this top arm. Finally, I need to pull his arm up straight to support his head, and importantly, tilt that head up and point the chin down to the ground to protect his airway. I need to monitor him here now until help arrives, continually checking for breathing. If that changes, I need to reassess by rolling him back onto his back. Otherwise, you can keep them here until emergency services arrive.
So that's our DRSCAB demonstration.
I'm walking.
All right. But there's one thing that happens when we are not breathing adequately for ourselves. So our brain's not getting enough oxygen. And obviously our brain really wants that oxygen now. So it sends signals out to sort of our body. And one of those signals is called agonal breathing. What this is you'll just see movement of the mouth, but they're not going to be breathing adequately for themselves. So you shouldn't see any movement of the chest going up and down. I'm just going to really play this video, which is like a 10-second sort of snippet. Please pay attention to his mouth. It is a real video. We don't watch the whole thing due to the fact we no longer check for a pulse and the compressions are slow. This video was filmed in 2006, so it's quite old. Yeah, so just pay close attention to his mouth. He does end up surviving, but this is just highlighting this agonal breathing component.
Signs.
Do not touch patient. Analyzing rhythm. Check pulse. If not pulse, give CPR.
So you can see his mouth opening and closing. That's just that brain's reflex. All right. So that's the agonal breathing check. Recovery position, really important to get to put someone in this if they need it for airway obstruction, or if you ever leave them at any point. All right, or maybe they're breathing and you're waiting for help to arrive. So obviously very, very important to do it correctly. The recovery position can reduce a preventable death from an airway obstruction. So this is a big deal. And what this video now will just show you is that demonstration of step-by-step of how to put someone in the recovery position.
To roll someone into the recovery position, you want to roll them away from you. Move the hand that's furthest away out to the side, the hand that's closest to you onto the patient's shoulder. The trick is now to lift this knee up as high as possible as it acts as a leverage point. Lift underneath the knee as high as it will possibly go. Supporting the knee and the shoulder, gently roll the person over. Unhook the foot as it stops the person rolling back towards you. At this point now, we want to support the patient's head. You can use some material or take off your t-shirt, whatever you need to support the head. The other option is to use the patient's own arm. To do this, just gently lift the head. You will need a little bit of force, but you want to pull the bottom arm as high up as possible and rest the patient's head back on their own arm. Make sure the chin isn't tucked into the chest, as we want to have a nice open airway. And you may just want to open that mouth a fraction as well. You can use this bottom arm as a support so the patient doesn't fall too far forward. In this position, make sure the patient keeps breathing by having one hand on the stomach, and we want to make sure that that rise and fall continues. At any point, if you notice the breathing has stopped or has become rather laboured, you do need to grab the patient's clothes, pull them back across, and commence CPR again.
Awesome. So that's just the recovery position. So back to our primary survey now, and we're going to now do the last C and D. And, you know, we've checked someone's breathing. We've done it for 10 seconds. We're looking for that rise and fall of the chest and feeling that. And, you know, we don't see any movement, or maybe it's abnormal. Maybe it's less, like one breath in those 10 seconds. So what are we going to do? CPR. And the other piece of equipment we really need right now is the defibrillator. So CPR, the compression to rescue breath ratio is 30 compressions and 2 rescue breaths. But we don't have to do the rescue breaths. That's optional. If we don't do rescue breaths, we just don't stop our compressions for the rescue breaths. We just keep going. We have about 6 to 8 minutes of oxygen in our lungs that can be utilized when we do stop breathing. So you're still pumping something around now. However, you know, breaths are recommended as sort of best practice if we do CPR. And if we need to give rescue breaths or want to give rescue breath, to do that, when we get to 30, we stop our compressions. We make sure that head's tilted back. We pinch the nose and we deliver 2 breaths before recommencing our compressions again. With that, our compression sort of in a minute is around that 100 to 120 compressions per minute. So it's almost to a second. So pretty fast. Where do we put our hands? Well, we put them in the center of the chest. All right. The easiest way to find someone's center of the chest is you put your hand under their armpit and you just drag it to the center. And how deep are we going to compress? We compress 1/3 of their chest. All right. The thing that you do is you pump fast and hard. All right. You sort of push until you feel that resistance. You can't just flatten someone's chest. Okay. Hand positioning, it doesn't matter what sort of your hands are like, interlocked, one over the other, comfort. That's the main thing. And you may break a rib. You just keep going. People die from CPR not being adequate, not from a broken rib. But also try and stray away from spreading that weight out. Try and keep it in the heel of your hand, in that palm, in that center, because you can break ribs from spreading that weight over sort of the side and sort of clubbing that chest. But with CPR, the main thing is you are actually manually beating that person's heart for them. Every time you do a compression, you're pumping the blood in the heart around the body. When you allow your hands to come back up, and recoil is very important, you're now allowing that heart to fill up with blood again before you can press and push it around. So make sure that you do it properly. And if someone tries to give you a tip, take it as feedback, not actually as a negative. There's 4 times you can stop doing CPR: when they show signs of life. All right. Maybe you're physically exhausted and unable to continue. There's a danger, you'd stop. And the last reason would be if paramedics arrive or someone comes to take over. The most important thing is we want to minimize time off chest. So if paramedics arrive, they need to be ready to take over. Just because you see the truck arrive doesn't mean you stop your compression. So wait till they come over. They probably will ask you to keep going if it's good compressions, but make sure that time you stop your CPR, someone needs to be ready to go as soon as possible. And the surface we do our compressions on are the ground. So a hard, firm surface, not a car seat, not a bed, not a table, all right, on the ground. Even if someone's been in a car accident, all right, and you can get them out, you're going to get them out, because CPR just won't be adequate in the car. And, spinal, well, we need to save someone's life for that to matter. All right, you will be protected by that Good Samaritan Act for that reason. So when you do CPR, maybe you're giving rescue breaths. There's this thing called face masks or face shields. They're like a protective barrier that goes over the person's mouth, and it's like a one-way valve. And common mistakes I've seen, and really common mistakes most people sort of see when it comes to CPR, is your compression isn't deep enough. So remember, deep and fast until you feel that resistance, and not allowing that chest to fully recoil. So always take your time, and your adrenaline might be pumping also. When someone's pregnant, CPR is slightly sort of a different position. And that's because that baby's weight is actually compressing on the major blood vessel that returns the blood back to the heart. So because of that, we need to slightly put something under the mum's right hip and put them in that left lat type position, but we still want their upper back. So their upper back and shoulders flat on the ground to form that resistance. So it only needs to be a slight tilt, enough to just push that baby's weight off to the side and return that blood flow back 100%. The one thing I sort of say is females are always right. We're always right, remember that. So always chuck it under that right hip. But that's just CPR when it comes to someone who is heavily pregnant. With that, handing over CPR operator because you're getting tired or someone's come to take over the care. Tracy's going to demonstrate this in the video, all right? So pay attention to when she wants to hand over and it's going to be shown and explained. But we'll put this video on now.
We now have a patient here who is unconscious or unresponsive and they're not breathing effectively. They're in cardiac arrest and we need to start CPR. Finding the center of the chest, that's where your hands are going to be placed when you're doing your compressions. Using the heel of your hand right in the center of the chest, in between the nipples, making sure you've got straight arms. You can either hold your hands like I have here, or you can use another technique. It's up to you, whatever feels comfortable. Finding the center of the chest, arms straight, leaning your body weight over the patient. You need to push down 30 compressions, 2 breaths, which I'll demonstrate shortly. Also ensure you push a third of the way down, allowing the chest to recoil, and we're pushing at a rate of 100 to 120 compressions in 1 minute. It'll look something like this. Seven, 28, 29, 30. Also make sure that you've got a face shield when you're giving your breaths. Tilt the patient's head back, pinch the nose, make a good seal with your mouth over their mouth and give 2 quick breaths. Following your 2 quick breaths, you're going to jump straight back onto the chest and continue with those compressions. At this point, hopefully someone brings a defib to you. The defib will tell you what to do if you've never put one on before, so just follow the directions.
Remove square package from the lid of the AED. Peel one of the white pads completely from the blue plastic. Peel one of the white pads completely from the blue plastic. Firmly place the pad without the blue plastic on the patient. Next, peel the second white pad from the blue plastic. Firmly place the second pad on the other location. Firmly place the second pad on the other location. Do not touch the patient. Analyzing rhythm. Shock advised. Do not touch the patient. Shock will be delivered in 3, 2, 1. Shock delivered. Start CPR.
Straight back onto the chest. I'm now going to show you how to do a changeover in CPR operator. It's really important to do this every 2 minutes or whenever you're starting to feel fatigued. Sam, I'm getting really tired. Do you think you can come and swap with me? Just get as close as possible to the mannequin. On my count of 3, I'm going to slide my hands out and you'll slide your hands in. 1, 2, 3. Great. Another way you can do this is when you're at the breaths, which I'll now demonstrate as well. Sam, I'm getting really tired. When I go down to give breaths, I'll get you to put your hands where I am, wait for me to finish giving the breaths, and then continue with compressions. 25, 26, 27, 28, 29, 30. Great. If at any point your patient starts to breathe, you need to make sure you stop doing CPR. Leave the defib pads on the patient. You can close the defib machine though. At this point, we need to roll the patient into the recovery position, and I'm going to demonstrate that on Sam.
Alrighty, so that's just CPR and defibrillation. We're just going to quickly talk about defibrillation now. So defibrillators, they do come in different shapes and sizes. Obviously a range of prices depending on the one that you actually want. Usually they're called AEDs sometimes, and that just stands for automated external defibrillator. It just means it's going to do it all for you once you turn it on. You'll find obviously the pads in there, but also scissors, razors, and maybe a towel to dry someone. And there's just different types. You might have to press a button to deliver a shock, or maybe it's like the one that just was shown in the video where it just is an automatic countdown, 3, 2, 1. But where do we put the pads? Well, we put them on the skin, and that's what the pair of scissors are for, and the towel to dry it, and the razor. But the most common position is actually called the driver's side seatbelt, so the top right, bottom left, like you can see on this photo. So adults are above the age of 8. So over 8 adults, top right, bottom left. There is an alternative for the center of the chest and between the shoulder blades on the back. And that's for people who are obviously extremely large. But the issue with that is rolling them on their side. So if you can't, it's a danger, or you just can't physically do it. Top right, bottom left is fine. Anything's better than nothing. Children are 1 to 8. All right. Hopefully you have children's defib pads in your defib. If not, you can actually still use adults. So adult pads, because they're bigger, all they can do for a child is center of the chest and center of the back between the shoulder blades. But you can roll them due to their size usually. Infants, we don't defibrillate. So we don't need pads for an infant under 12 months of age, all right? So we put our pads on and we turn our defib on, and it does about 60 to 90 seconds worth of instructions like you saw in the video, and it tells you do not touch the patient, analyzing heart rhythm. It's only going to tell you 2 things: whether a shock is advised, and it's going to go through the shock and deliver it and then tell you to start CPR, or it's going to tell you no shock advised and only to continue CPR. So it can't shock the person. And that's because we've got non-shockable and we've got shockable rhythms. Our heart has its own pacemaker, and that pacemaker fires off electrical current, which makes the heart beat. And you can see when there's movement on these rhythm strips, it means there's electricity going through our heart. All right, when there's no movement, as one of them shows, there's no electricity. Our heart is still. They are clinically dead. The AED, so the defib, will not show you this information though. All it's going to do is tell you whether a shock is advised or no shock is advised. So just follow what it tells you. So we've got 2 non-shockable rhythms, and they're our left-hand side rhythms. All right. Normal sinus rhythm is a normal heartbeat. Electrical currents going through. So what we never do is put defibrillator pads on someone who is conscious and breathing. They're in normal sinus rhythm. They're in a non-shockable rhythm. We don't need the defibrillator. All right. A defibrillator will never shock someone in a normal rhythm, but we don't know that because we just never put it on someone who is conscious and breathing normally. All right. However, if someone's unconscious and not breathing, and we put it on and they tell us it's no shock advice, continue CPR, they might be in asystole. So flatline. Our heart has no electricity to start with, so it can't add that external electricity like the defibrillator is for. So that is a non-shockable rhythm, and I know they shock it in all the movies. It's just wrong. All right. We've got the 2 shockable rhythms on the right-hand side. Ventricular tachycardia, ventricular fibrillation. So VT, tachycardia means too fast. Fibrillation, so VF, means erratic, chaotic, abnormal. It's just all over the shop, irregular. All right, there are 2 shockable rhythms. The defib is looking for to shock, but it doesn't tell you they're in which one they're in. It just tells you that they're in a shockable rhythm, and it wants to deliver the shock and to obviously make that safe, that scene safe. It's because it's got electricity. We can add that other bit of electricity and work together with what the heart needs. What the shock will do is pause the pacemaker firing off the signal. And as you start CPR again, it's hoping that because you doing CPR is what a heart should sort of be doing, it tries to pick that up and fires off those same type of sort of rhythms. But CPR needs to be done straight away after a shock. All right. Shock might work first go, might work after the 5th shock, might never work. Who knows what's going on. All right. But what it will do is reanalyze the heart every 2 minutes. So you'll be doing for that 2 minutes of CPR until it does it again. So that is defibrillation. All right. Any questions? Again, like I said, write them down, ask your trainer on the day of your face-to-face training. But we're going to now move on to infants. All right. And we'll play the video that demonstrates everything to do with infants.
I'm now going to run you through the changes between adult and infant. We're still going to check for dangers and make sure the scene is safe, and then check for a response. Loud noises, you can check for a grip reflex, you can tickle the toes, pinch on the nose, that's the pain response. If you have no response, make sure you send for help. Checking the baby's airway is slightly different. We don't want to tilt the head back. Instead, you might want to pop something just underneath the shoulders that gives a nice little lift and allows the head to remain in a neutral position. If you don't have anything available, you just want a slight tilt, not a full extension. We then also need to make sure we check the nose for any mucus that might be blocking, as babies tend to be nose breathers rather than mouth breathers. We then will move on to our breathing check. To do this, hand on the tummy, ear down to the mouth, or you can just use 2 fingers at the mouth. We're going to look for rise and fall, 10 seconds. Babies tend to breathe faster than adults, so you should see some more breaths than what you will with an adult. If a baby is blue, it's probably not breathing enough, so then you'll start CPR. Fingers in between the nipples, using 2 fingers, push down. All the numbers stay the same. We're pushing at a rate of 30 to 2, a third of the baby's chest, and 100 to 120 compressions in a minute. 25, 26, 27, 28, 29, 30. When we give a baby its breaths, it's important that your mouth covers the nose and the mouth, and it's only a puff of air, about the amount that you can hold in your cheeks. And then straight back onto the chest. If the baby starts crying, that's a good sign. You'll want to place the baby into the recovery position. To do this, support the head and neck. Baby would go over the arms, allowing any mucus to drain out.
Alrighty, so that's just infant, the primary survey for infant, and also CPR. So before we wrap up the training for the CPR bit, we're just going to quickly cover heart attacks, because they're sort of one of the things that people think about regarding a sudden cardiac arrest the most. And what you can see is that our heart is a big muscle, and our heart has coronary arteries that supply that muscle, that oxygenated blood. What is happening when someone is having a heart attack is the blood flow to perfuse that muscle is actually blocked. And obviously that blockage stops that oxygenated blood getting past. And without quick treatment, that muscle begins to die. With quick treatment, you may prevent or limit the damage to that heart muscle. So signs and symptoms is chest pain, pressure or tightness, left arm, neck, jaw pain, between the shoulder blades, lower back, all right, right arm, okay, that it sort of can be different for everyone. Shortness of breath, dizzy, lightheadedness, or maybe they feel faint, nausea and vomiting. Maybe they've got clammy skin, pale and sweaty. Sometimes people might feel an impending doom, or maybe worst case cardiac arrest. So our treatment is, obviously we want to position them in a way that they're comfortable. Laying on the ground is perfect if they're dizzy. Obviously stops them from falling if they're on the ground. We want to always call for help. We want to treat someone who's having a heart attack as if they are we want to treat someone who's having chest pain as if they are having a heart attack until proven otherwise. All right. We don't want to risk it. We always treat it as the worst, because then we're treating it as if a cardiac arrest could occur or is occurring. We also want to communicate with our patient, talk to them, ask them questions, ask them about their past medical history, any medications or allergies they have. There is a condition that's very similar to the way that a heart attack presents, and that's called angina. What angina is, it's like a narrowing of those blood vessels, all right? Someone who knows they've got angina probably actually has a medication they take, and they should be able to administer that themselves. And it's called GTN. It's a nitrate spray, and it just relaxes those blood vessels. But if that doesn't work, they've got unstable angina or heart attack, and we just want to obviously treat them as if we would a heart attack, get them to hospital. You might be on the phone to 000 and giving them the information, and they ask you, do you have aspirin? All right, aspirin's given to obviously prevent further clots forming, that sort of clotting cascade, and it sort of acts as like a mild blood thinner for it. So what 000 might direct you to give is 300 milligrams of aspirin. They chomp on that prior to paramedics arriving. But if you don't have it, don't worry, paramedics will give it when they arrive. But anyone can have a heart attack. It doesn't matter their age. One of the most sort of the biggest things that comes with heart attacks is actually family history. And I've treated 21-year-old females who were fit and healthy and that had heart attacks before. So we always want to treat it as if it's the worst case. All right. But that is heart attacks. Just in regards to what you're going to do during your face-to-face training, you're going to have to go through the assessments, being that DRSCAB, recovery position, using the defibrillation, how to handle someone who's regurgitating, handing over to someone else whilst doing CPR, 2 minutes of adult CPR, 2 minutes of infant CPR. And if you are actually doing the childcare course, you'll have to do CPR on a child, which is just with one hand. But that's it for the CPR element. Just before we go, obviously CPR or anything traumatic does have a psychological effect on someone. There is help out there. All right. So we all cope with traumatic events differently. It is normal. Look after yourself, but also look after people you care about. So friends and family, and maybe strangers, colleagues. PTSD or PTS, post-traumatic stress, is just a reaction developed from a traumatic event. So anything can cause it for anyone. Signs and symptoms are emotional or mood changes, sleep disturbances, appearance changes, withdrawal. But there is heaps of help out there, and it's not just limited to the ones on your screen, okay? There's Men's Helpline, Suicide Callback, Mind Health, Google, you could find heaps. Or your workplace might have its own protocols. But that's it for the training today. What you're going to do now is obviously book in your face-to-face assessment day, or continue on after a break to go through the first aid part of this course. But thank you.